Good morning and welcome to all who are attending in person and online. This is the next in a series of lecture which celebrate the history and the heritage of our departments in Christian Medical College Vellore. This gives us an opportunity to look back at where we were, where we are standing today, and to dream and aspire for a better tomorrow. Today's lecture focuses on the Department of Critical Care Medicine, and we will be privileged to hear from the stalwarts who were instrumental in the development of this department. Today's session will be moderated by Dr. Shalini Nair, Professor and Head, Critical Care Medicine and Neurocritical Care, and I'd like to invite her to take the proceedings further.
Thank you, Dr. Weber, and we thank the administration for giving us this opportunity, one of the youngest departments, to showcase our glorious history. Let's start with thanking God for this momentous occasion. I invite Dr. J.V. Peter to lead us in prayer.
Let's pray. Most gracious and loving Father, we come to you in Jesus' name. We thank you for this opportunity that you've given us to be here as a Department of Critical Care, to recall the numerous blessings that you have showered upon this unit and upon our institution. We pray that you will be with us in these proceedings, and as we continue to serve this institution, serve the nation, and serve you, we pray that you'll give us grace in abundance, that we may be true to our calling to serve and not to be served. We ask all this through Jesus' precious name. Amen.
Our journey, critical care journey, started way back in 1952 when Padma Bhushan Dr. Jacob Chandy thought that intense monitoring was needed for his neurosurgical patients in the neuro ward. Today, we stand at the cusp of our 75th anniversary next year. And from there to actual development of Division of Critical Care took decades. It was in 2002 by the merger of medical, surgical, neuro, and pediatric critical care that the division came into existence. Dr. Chellam Kirubakaran was the first head of the division. I'm hoping that ma'am is seeing this live telecast in Australia. Thank you, ma'am, for all your leadership. From there, today we stand on the shoulder of giants who not only dared to dream that critical care services could be provided in our setup, and leading the way was Dr. Ray. His vision and his caution on the use of mechanical ventilation laid the path for the present critical care. I invite Dr. Binala, the present head of medical critical care, to give him a memento representing our gratitude for your leadership. Dr. Prakash Khanduri tirelessly took the effort to make the world realize how eminent the need for surgical critical care was. And from his efforts, we bear the fruit of the present surgical critical care. I request Dr. Shoma, the head of surgical critical care, to hand over a memento to him. Thank you, sir, for your vision. What Dr. Khanduri dreamt of was realized and put in practice by Dr. Nandini. Thank you, ma'am, for all your hard work. From there, the evolution of critical care to the present day was by the builders. Let's hear from them by themselves how hard it was to come to this day. And the tallest of them, I will request to come first, Dr. Mathew Joseph, the former founder of Neurocritical Care.
Thanks. Thank you. So what I've seen of the previous heritage lectures was it was all pictures. So when I was asked to do this, I naturally went looking for pictures. And I'm a very organized person. I have my photographs per year And every year has a folder called ICU of pictures taken in the ICU, about the ICU. I'm very organized. All right. But when I went into the folder called ICU, unfortunately, I have no pictures of the ICU. All my photographs are people. It's all the people of the ICU. I do not have a single photograph showing ventilator, monitor, structure of the ICU, nothing. All my photographs are people. All right. ICU sort of comes peripherally. You're taking photographs of people and you can see a bit of the ICU. But I don't have a single photograph showing the building or the structure or anything. It's all people. By the way, notice our excellent design with plug points within a foot of the patient's head. Anyway, that's just a minor aside. I've taken photographs, but usually to find fault. Torn sheet, dirty floor, dusty surface. But that's all the photographs I have. I don't have a single photograph of the ICU, so I apologize for that. So like Shalini said, we structurally were the first ICU. Okay, N1 ICU was built with a post-op room. N1 ward was built to the post-op room, which we call the N1 ICU in 54. N2 ward was built with an ICU in 63. So structurally, we're the oldest, which actually proved to be a disadvantage. Because remember, those were built when there were no monitors, there were no ventilators. All care was provided by just clinical nursing, doctors, whatever. And for the longest time, till the mid-90s, when I started taking interest in critical care, there was nobody in charge. So equipment, development, nothing happened. And when I actually took over and tried to do things, it was very, very difficult because the buildings are so old. You couldn't break down a wall between two rooms because there were no structural pillars. That building is so old, there were no structural pillars. They were just solid wall. And we couldn't break down walls, so we couldn't make big rooms, nothing. So when we started the neuro ICU, we had N1 ICU on the ground floor, 6 beds, N2 ICU on the first floor, 6 beds. Separate nursing teams, often antagonists to each other. Downstairs they need an ambo bag. Upstairs people say, no, ours we won't give you. Same group of patients, but 2 competing groups of nurses. It was an interesting dynamic. Then soon after that, I moved the ICU downwards, the upstairs ICU downstairs, by taking over 1 single room and 2 single rooms and 1 double room of N1 ward, on the agreement that upstairs the ICU will become 2 double rooms. And we moved downstairs. And it was quite an exercise integrating the 2 nursing teams, but it worked. Then upstairs, I went to the then director, Dr. Mathan, and said, rather than making 2 double rooms, I want to make it into an HDU. And he looked at me and said, have you heard the story about the Arab and the camel? Okay. That was the reaction, but he gave us permission. So then we went up to 18 beds, 12 ICU downstairs, 6 HDU upstairs. Then from 2007 to 2011, I wrote letters to the administration. The Chinese water torture, drip, 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 emphasizing the same point over and over again, because we were sending away most of our head injury patients. ICU was full of neurology and unit neurosurgery. On average, there would be 1 neurosurgical patient, 2 neurosurgical head injuries in the ICU, which I was kind of upset about. So finally, in 2011, we got permission to convert part of N2 ward to trauma ICU HDU. So we finally ended up with 16 ICU beds and 12 HDU beds upstairs. All right. And that is how things stood when we transferred to the surgical ICU. I mean, to the Ranipet campus, where, of course, now we have 50 beds and we are rich. That's all that's left of a place where I spent 35 years of my life. Okay. That corner there, that yellow tiled bit, if you can make out, is where our ICUs were. And this was our post-op ICU. It's a bit foreshortened. But if you want to know the dimensions, it was 28 by 14 feet. Okay, which is maybe the little more than the length of this platform, size of this platform, wider. Okay, and if you look at the far wall, there was sink, there was shelf, there was computer on this side, and in between we fitted 3 beds. The beds were so close together, if you wanted to put a trolley to transport a patient, you had to move both the beds aside. There was no place for a trolley between 2 beds. We were that cramped. All right. Even when we modified upstairs, we had to accommodate patients. So we couldn't really create space. So even upstairs, just before we moved, we were fairly cramped. Now, we are in Clover. The space where I can put 3 trolleys between 2 beds without having to move either bed. All right, infection control, patient management, everything becomes so much easier with this space. And if you do rounds morning and evening, you get 10,000 steps. You don't need to do any exercise. This gives you your steps for the day. All right, it's amazing how far we've come from that cramped this thing. When we took over the ICU, downstairs ICU had 2 multi-parameter monitors and 2 pulse oximeters. So we monitored like this. Multi-parameter monitors here. Their pulse oximeters on next bed. And the last 2 beds had 2 pulse oximeters. That is our monitoring for the ICU. Upstairs, for 6 beds, we had 3 of those. I don't think any of you are old enough to remember it. The single trace, one blue trace on a black background monitors. We had 3 of them for 6 patients. All right. That is our monitoring upstairs. And we had 1 syringe pump. It was a giant thing. It was about 1 foot tall, about 1.5 feet long. It was a very impressive looking piece of machinery. It worked fairly well, but you had 1. All other controlled infusions were micro drip sets. Again, I don't know how many of you are old enough to remember micro drip sets, but they were micro drip sets. You counted drops for, that time dopamine infusions, etc. Sorry. Now, that's a potential organ donor being kept alive in the ICU. We would never have been able to do this, even 10 years ago. Yeah, you can count, man. You can count how many there are. Yeah, we could never have dreamt of this, having that kind of equipment in the ICU. There is so much now that we can do in the ICU, which you couldn't do before. The jewel of any critical care is the people. And if you look at the letter, I'm asking for, there are 2 faculty positions. Can we make the second one a non-PG? So you get junior doctors. Okay. This was the cadre of the neuro ICU when we had 18 beds. 1 non-PG, 1 SHO. 2 junior doctors for 18 beds. That's why we started. All right. The big transformation came in 2007 when Shalini joined. I ran the ICU before that on rule of thumb, rule of toes, on whatever it is. Because I had no theory. My training was neurosurgery, not medicine or critical care. Okay. When I was a PG, if patient had chest pain, what is my response? Call cardiology. Now suddenly I was responsible. So, but I used to run purely based on what I knew had worked before, not with proper knowledge. Okay, Shalini brought in knowledge, etc., which really vastly took us a massive step upwards. That's our duty roster now. Compared to 1 junior doctor, 2 junior doctors, we have SHOs, we have DM residents, we have faculty, we have Shalini, Trifina, Prishel, Nirupama. We have, it's night and day compared to what it was to what it is now. We had 21 nurses. The ratio at night, it was 1 nurse and 1 A&M for 6 patients. That was the duty roster. I must say now that the nurses we had at that time were brilliant. I learned a lot of my critical care from the nurses there. There was nobody else to teach you. The nurses were very, very good. I've tried to maintain that tradition over the years in our ICU. But we lived life on a razor edge. That is, once we had a measles outbreak among our nurses. 4 nurses got sick. We shut down 1 ICU. Yeah. Now we have 110 nurses. 4 nurses disappearing will not make any difference to us. All right. Our first person to do technical help in the ICU was a person called Sahai Raj. Unfortunately, we don't have his photographs. After that, we had Mr. Gopinath and Mr. Narayanan. They came in, like me, with no medical knowledge, all right, learned on the job, and are still with us doing now mainly equipment this thing. They were therapists and equipment maintenance before. Now they do basically equipment because now we have 15 trained therapists who can do things that we couldn't imagine. So what I would like to say about the care in our ICU is I don't know if an order of magnitude is enough to say it. It's what we could do and what we can do now is incredibly, incredibly more advanced, more developed. A patient who comes in now has such a good deal compared to what used to happen 30 years ago. It's incredible. The difference is, unless you've lived through the entire experience, you cannot begin to explain how different it is. People, place, equipment, whatever it is, the changes are incredible. When we started off, it was only practical. If patient does this, do this. Okay, now we have formal training therapist programs, we have formal nursing training programs, we have DM training. Our ICU is recognized all over the country. We have a Fellowship of Neurocritical Care. Shalini is the secretary of the College of Neurocritical Care. We are, again, like I said, the progress has been amazing. All right. I just pray that it continues. Thank you.
We now move on to the surgical critical care. I was fortunate to be part of the development in its not so early days, but to take us through the hurdles faced in the formative years and how it was challenged, I invite upon Dr. Nagamani Sen to tell her part of the story.
Hello. Good morning, everybody. How do you do this? Okay, is it? This one. No, okay. So 1989 it started. How it started, there was a need, but there was no SICU. So everybody was thinking about it, the need, because I was intern at that time when it started. And this is how it is, okay? It was 1970s to 80s. All the interns who were posted in the surgical wards, we are doing only roster, okay? Looking after sick patients in Prakash Kanduri's unit. I first came, I got a shock of my life. They said, patient arrested, okay? So everybody has to run here and there. The nurse will say, what is the hurry? I'm supposed to be on off, okay? Then somebody will say, coming doctor, ventilator, we have to ask Dr. Ray, and Arthur will bring, he only said, we are coming, I haven't had even coffee even yet. Then one fellow bringing the oxygen cylinder from somewhere, okay, he's saying, kadavale, how to, because this is second time, third time, I'm always carrying the oxygen cylinder, big or small. And patient arresting, the intern is shouting. Okay, this is how it was. And then it started islands of care everywhere. Good, we are not that sick. The other patients are talking in OG ward. The fellow who is sitting on a roster is so tired because he is coming from labor room and now sleep on the ventilator. So this is the situation. And surgery ward also, ventilator will be malfunctioning, doctor panicking. That is, doctor is me. I really panicked because I have never seen a ventilator or how to bag, how to connect, how to intubate, nothing we know, but we are put on a roster continuously. And the others are complaining, too much noise, can't sleep, the patients, but we are sitting there. Like this, when I was posted in one of those, roster type thing, the ventilators used to be very huge. And we have this Bennett ventilator has to be connected. My night duty roster, I'm always scared that when is this ventilator, the oxygen going to finish? How am I going to connect it to the ventilator? So that time, the savior who drew all these pictures, my husband, he came. He's always there when I'm there, because I just said, I don't know how to connect this, connect that. So that way we sort of got friendly and courted and married. This intern internship has made me sort of friends with. He really helped with this ventilator, and he's already teaching. And he took me to Dr. Ray's unit and showed me all the ventilator, teaching so much. And not much blood gases were there those days. No monitors also. So care of sick surgical patient was disorganized, disjointed, delayed, and a disgrace. So that time they said we should start. Meanwhile, I finished my anesthesia training and went to Australia. When I came back, this ICU was getting started. So when shall we meet again? These three people are really, that is Dr. Nandini Korla, Dr. Prakash Kanduri, and Violet Jayachandran. She is the head nurse those days, so very, very authoritative and very good, very, very sensible what to do. Huh? So where is the place? Then they found a place between the old dietary department and OR recovery, one small place. And I entered fourth. So when I came back, I didn't join anesthesia, even though because I had some critical care training in Australia. So when I came back, they said, you join this only. So I was the first anesthetist posted in a surgery department. Okay. And this is the day of the opening of our surgical critical care. SICU. You can see all the big wigs there. And I'm also there, but I went there to serve coffee or something. That's why my photo is not there. Serving everybody. So this is Dr. Prakash Kandari Nandini. See how young they all look. In 1989, 10th April, they started. Not like 1954 and all, before I was born or something. Neurocritical care Madri. Then, but lot of teething problems were there. Huh? We are always sort of, what are the teething problems? Trust deficit. The surgeons don't want to trust the anesthetist whether they will be able to look after or something. And we have all the, that was a real problem. So there is always empty bed, empty bed, empty bed, because they don't want to put the patient. See, April 10th it started. Till 20th, why we didn't have a single patient. So I'm just teaching the nurses about the ventilator, this, that, blood gas. How long can you teach? Then when I come out, immediately Dr. Pulimud will be walking. Is there any patient yet? Nobody, nobody want to admit a single patient. So it was, then what happened was, one miracle happened. The neuro ICU was full. So they brought one neuro patient to our ICU, the isolated. So luckily that patient got saved. Then slowly, with this thing. Then next is high cost. Okay. So people even play this, staff entertainment program. They are showing that patient comes with coat suit and big suitcases. He's wearing a bill only at the end of it, because everything, so much of a bill. I mean, if you people have remember that staff entertainment, it was really a joke. So I couldn't even lift my head and I was looking like this and sitting. Then there was a special fund, sorry, in the red surgical HOD. Someone is eating our special fund, that is surgical ICU. Okay, so like this, lot of things, but it was fun. And we need lots more people, lots more. So all the anesthetists came, even ENT, OG, neuro, surgical, ortho, even the, like X-ray people want to come and get posted in the ICU. Like that, we became so famous. Okay, and the surgeons were also there. And first person who helped me a lot is Dr. Ponna. So he came, the surgeons don't want to get posted, but Ponna was pushed into ICU because he came newly, there was no vacancy there. So they put him in ICU, and twice a week he will go to Karigiri or somewhere he will go. And he was really a joker, but he was really a star, So my anger and his humor will sort of match very well. So we don't, everybody sort of, he will always say, she's coming, so don't say this, he will teach them all the juniors. It was very good. But then he had to go. After that, before that, Dr. Nandini left, then he came. Then we have John Prakash. He was also a surgeon who was interested in critical care. He was such a great help, and I really miss him. Now I think he's still doing critical care only in Australia. He also didn't want to go, but the family sort of, they have to go. And this is we wanted to expand because a lot of, so 12 bed became 18 bed. So this is the inauguration of the 18 bed. And at that time, George Chandy was director, very helpful. He will sort of, whatever you want, he will get it done. It was really good. Then this is again the prayer and Dr. Arthur. No, Arthur is also there, I think, somewhere. And this is the first liver transplant. It happened in 1999. And Madhu Hasra is still alive. And look at Dr. PK is feeding him ice cream. Huh? And happy birthday to Madhu Hasra and all that. And the team rejoice. And this is the anesthetist, Dr. Lalita. He's just, sort of spent some 24 hours in anesthesia. And George Koshi, in George Kurian, was gastroenterologist. How much they will come and feed them themselves, ice cream and all those things. Even now he supports him, I think. Then further developments, we had SHTU, AICU. Then we sort of united and formed a Department of Intensive Care, then started paramedical courses, and post-MD critical care fellowship also started one of those days. And Dr. Saro Devananda, I have to remember her because we were struggling with the nurses not to, proper the chest physio and all those things. So she said, why don't you start this critical care therapy course? So we applied and we got that. So she was the one who said, then you divide the nurses to the nursing care and the critical care people to the critical therapy course. Then these are the first batches. And now they are all big shots. They must be earning in lakhs because they are in Qatar. So like that, from here all over the world, they've got even in Australia. Our first we used to call it respiratory therapy. Then the respiratory therapy people were not happy. So we made it critical care therapy. Then they have started in Bangalore. Everywhere the critical care therapy has been started. So this was my first, there were 6 people. One fellow left, then another fellow is in Australia. His picture I didn't get. These 4 all, they look like big shots now. They were small before that, then and now. So these are all the meetings we had with all the, we had medical ICU and, neuro ICU. Everybody is there, all the motor. We had a beautiful, every discussions we had. We had a real good time. Even a pediatric ICU person is also sitting there. Then when the foreigner comes, we had a very good relationship with all the ICUs. And this is my retirement photo. Everybody is there. Jaya Kurvilla and this one, all of them. He is here. No, Jaya Kurvilla. So many people have gone abroad, like Jijo and, some people are not here. This is again a discussion in the nursing class. I also sat. So we used to have regular classes. This is another meeting with the nurses and everything. See the behind what have they written? All those. This is another, we made uniform for them. The second time when I went to Australia and came back, they were wearing all saris and touching everything. So we made uniform. So each year we changed the color of these uniforms. They were very happy to wear a pant and shirt instead of a sari. And, this came before itself. This is my retirement photo. Damayanti is there. They have been with us for a long, long time. This is Bharati. She has 20 years of service. How she tolerated me, I don't know, because anything she does, I'm finding faults, but she is very nice. So I have to remember her now. She had 20 years. I didn't have a photograph. This is from a cup she gave me with her photo. That from there I have taken the photo. Yeah. This is my Malati Chelaya. I have to remember her. She was our first ward sister. Very cooperative. She really helped us very much. But then she had to go. Whoever was very, very nice, they all left. And this is Damayanti, our ward clerk. This is my retirement photo. Bharati and Bhaskar is our technician. Very good. This is my gurus who pushed me into this surgical ICU from internship to anesthesia. 2 gurus. And this Subbu is taking over from me. He took over further leadership. He'll be speaking next, I think. And these are the future. They're all here. Shoma, Binina, Shalini, they have to carry on. And we have to, I have only one request to them. We must do some kind of a teaching or a conference. We used to have before, but that got stopped. So we should start so that, the nurses, everybody will get involved and learn more. Thank you. This is the growth.
Thank you, ma'am, for that wonderful story. Now to take us through the present stature of surgical ICU and the educational activities nationally and internationally of Department of Critical Care Medicine, we have the talk by Dr. Subramani. He's on his sabbatical, so this is a pre-recorded speech.
Good morning. It's a great privilege to be able to speak to you on two aspects of the
I'm currently on sabbatical leave.
medicine, this ongoing heritage series lectures. I'm currently on sabbatical leave in Brunei, and I'm all excited to realize that I'll be back in Vellore in the next 2 weeks and join my team. Surgical critical care as of today and educational critical care are the two aspects of critical care I'm going to discuss today. Surgical critical care you see today is the result of the foundation laid by our founders. And as the flyer rightly says, we builders worked relentlessly on the strong, unshakable foundation and developed the department over the years. Critical care is a teamwork, and every team member is equally important. I stand here in front of you acknowledging and represent my team of nurses, allied health professionals, namely the respiratory therapists, physiotherapists, dietitian, non-medical team, including the office staff, the cleaning staff, the doctors, admitting team, the surgical ICU team, who all work relentlessly to improve patients of the critically ill patients. As Dr. Nagamani spoke to you earlier, the surgical ICU was started as a 9-bedded unit in the year 1989. In the year 2007, when we had an increased number of patients, the administration gave us the old dietary area and it was developed into a 13-bedded HDU. Later, when critical care patient number increased, we swapped these two areas and we got a 13-bedded ICU and a 9-bedded HDU. Everybody used to envy the Department of Surgical ICU because it's huge, very spacious, and actually that helps in infection control. In 2009, A block ICU was taken over by surgical ICU. Though I was a bit reluctant when Dr. Nagamani took over the A block ICU, it has been a very, very fruitful experience and we enjoyed thoroughly the years we ran the unit. The trauma ICU or the surgical ICU in the Ranipet campus, as we call it now, was started in 2022. Currently, we have 20 beds functioning there, and we cater to the trauma patients from hepatobiliary, urology, and vascular surgery. Now we have the old surgical ICU refurbished, and we are all excited to be able to move into this area in the next couple of weeks. Over the last 2 decades, we have made significant strides in patient care, in education, critical care education, and delivery of safe, good quality, and affordable care. And I believe that we have set good standards in critical care medicine. These are the statistics, and as you can see, the turnover rate and the bed occupancy rate are quite high. This is the surgical ICU in the town campus, and this is the data for the surgical ICU in the Ranipet campus. Patient care is always a first priority. We never turn down any bed request, whether it is a medical patient or a neurosurgical patient or a pediatric patient. We always admit it. Similarly, other units also admitted our patients. So we admit these patients, and when the beds are available in the other ICUs, we'll transfer them back. We also realize that patients are being ventilated in the general wards, and that takes away the care of the other patients. So we actually have totally stopped this practice of mechanical ventilation in the wards. We also developed an outreach team which would go out to the wards when we get a call, try to stabilize them in the ward and leave them there, or bring them along to the surgical ICU. And what we found was that the transfer of these sick patients without stabilization and without the ICU team coming increased the morbidity and mortality of our patients. So that's why we had this outreach team, which actually has improved the outcome. We became a multidisciplinary ICU for a few years, and even still we admit medical patients. At one stage, we had a patient floor was about 20 to 25% of them were medical patients or per medical specialty under wing. This is only in surgical ICU. I'm not including A ward ICU where we had more medical patients. COVID-19 was always a challenge, and we actually admitted patients for the non-COVID cases from the surgical, medical, and neurocritical care units. We also have a COVID service running in the AICU with 13 beds, and we had the HDU converted for screening purposes. And the patients who were treated in the COVID ICUs were later stepped down to a unit for further management. Education has always been an important aspect of critical care, and we'll talk about this shortly. Safety and quality is important, and we followed international recognized checklists. We had a daily review which helped the trainee to fill in and get all the details of the patient if they go through step by step. It's a learning process, and central line insertion checklists was modified according to our local needs. We also had the VAP prevention bundle, intubation and tracheostomy checklists for every patient who has undergoing endotracheal intubation. All these checklists were thoroughly followed. This actually has reduced the incidence of any untoward events. After my training as a critical care nephrology, we came and also started a renal replacement checklist to understand the science behind the renal replacement and also run it safely, though it is run by the nephrology department. We also had the referral checklist for doctors to take to the wards when they had referrals from the ward, so that they have all the full information when they call the senior. We had to do some soft policing. So there's the critical care therapist or the nurses will be watching over the doctor doing a procedure. This is in this case the central line, and they will, if the normal protocol is not followed, they will remind them, and they also have the right to stop them doing the procedure. But in our culture, it doesn't happen. But they used to tell softly they have the right to do it. Infection is a big killer in the ICU, and we need to do everything to prevent infection. One of them is the CDC recommends is a total full body drape. The patient is covered from head to foot. So this is a picture of the full body drape, but it's being used for a percutaneous tracheostomy here, this situation. We use ultrasound for vascular access, and the probe has to be sterile. And these covers keep them sterile. The commercially available covers are very expensive. So we got the medical devices company to make us a cheap cover for the probe. And this is a setup where you can see a patient. This was a really sick patient. So we had the full body drape, and we had access to both the jugular area and the femoral area. So various lines were inserted for this patient. And you can see the probe with the cover in the middle of the picture. And so with one drape and one probe cover, we did two procedures. So it was time saving, it was cost saving, it was safe, and it was sterile for the patient. So that is the whole idea of our innovating or things in critical care. The next is the prevention of infection through these arterial transducers. So the medical devices company made us a silicone sheath which will cover the plunger. Otherwise, the plunger gets contaminated every time you use it. So it is covered like this. And people who have worked in the critical care units will recognize this setup of arterial line transducers connected with a syringe. So how does this help? There is a separate port. This is also a special port made by the medical devices company based on our requirement. It has a rubber port which does not need needle for introduction. It's a diaphragm. So you can use a 2 cc syringe or a 3 cc syringe and directly enter the cannula. So all you have to do is to clean this area. So you see the blood is drawn into the syringe, and we connect the syringe and aspirate. So there is no spillage of blood. There is no wastage of blood. The infection risk is very, very less. And more importantly, there is no risk of needle stick injuries because there is no needle use anywhere. The other area we worked on is the HFNC, the high flow nasal cannula, which became very popular during the COVID time. But we have been using it even before that for type 1 respiratory failure. So on the left, you see the commercial kit, which can cost, the unit itself will cost 3.5 lakhs. For every patient, you need the disposable kit, which is the circuit with the nasal cannula, which comes to about 7,000 rupees. We assembled the whole device for 90,000 rupees, which is almost one-third cost, or one-fourth of the cost of the commercial machine. And we got a medical device company to make the cannula, and we got a single limb, heated limb circuit for the cost of 1,000 rupees. So this, though currently we don't use this machine setup because most of the ventilators have the high flow setup, we are using this circuit, which is now only 1,000 rupees compared to the 7,000 rupees given by the other company. So the cost is much less, and we use it very widely, and all the ICUs use the circuit. The other area we worked on is this intra-abdominal pressure, which is very common in medical and surgical patients, and this is how a pressure looks like. And high intra-abdominal pressure can cause abdominal compartment syndrome, and patient can become really sick, including the renal failure. So what we used to do earlier was this Abdvisor kit, which is a commercial kit, which sometimes is hard to come by, it's more expensive. And so we decided that we have to do something about it. And when we don't get the kit, this is what we did. We introduced a 20 gauge cannula into the urinary catheter, and we recorded pressures through that, which becomes a bit unsterile. So we developed this connector, which goes connect to the urinary catheter and the bladder, and we can measure the pressure in a more sterile manner and in a safe manner. So this is how we actually try to maintain the quality and also cost reduction in ICU. So our vision from the surgical ICU for the coming years is to improve the quality of care, train all the doctors and paramedical staff to prevent patient becoming critically ill, to recognize critically ill patient early, and also to stabilize and transfer them to ICU safely. Cost containment is also a priority for us, knowing that the cost of ICU care is kind of skyrocketing. Antibiotic resistance is very common, and we do a good deal of work in the antibiotic stewardship, and research, of course, is important. These are the areas we want to work upon in the future. The second topic is the education and critical care. So it includes both medical, allied health sciences, and nurses. We have medical university-run recognized courses before the introduction of university courses in critical care medicine. The undergraduate, postgraduate, and super specialty trainees rotations used to be in our ICUs according to their curriculum, and also the interns used to be rotating to the ICU. So these were the contribution of the critical care in earlier days. Later, we developed this program, or we enrolled to the program of DM of Critical Care Medicine in the year 2015. To start the DM in Critical Care Medicine, we had to have a Department of Critical Care Medicine, which the seats were sown in the year 2002, and a division of critical care was formed. The creation of this division was possible with the support of the parent departments, namely anesthesia, general medicine, pediatric medicine, etc., which allowed people who had the interest in critical care to work in these critical care departments. So initially, the department comprised of the surgical, medical, neuro, and pediatric critical care units. Later, it is now currently it is comprised of the surgical, medical, and neurocritical care. And these are the list. This is the list of the heads of departments till now. In 2013, after my return from sabbatical leave, I was given the responsibility of getting the university and MCI approval for this DM in critical care medicine, which was just approved by the MCI in the year 2011. It was an uphill task, but then the predecessors, Dr. George John and Dr. Nagamani, had done a lot of groundwork, and including development of the curriculum and presenting to the MCI. So it was not that difficult to get approval. In 2015, we got the approval for DM in critical care medicine. We got one seat, and Dr. Binla Chapa was our first candidate. Subsequently, it increased to 5 seats in 2019 and 9 seats in 2026. And this actually has helped us to expand our departments. With the increased number of faculty, the teaching has grown leaps and bounds, and we have regular teaching sessions, including bedside clinics. Allied Health Sciences Critical Technology course was been there from the year 1980, which was like a in-service training, and Dr. Ray and Mr. Arthur Sadanandam, which you can see in the photograph, were the two people who started this in-service training. And later, the year 1997 to 2011, we had the Diploma in Critical Care Technology. Later, in the year 2011, it was converted to a BSc in Critical Care Technology. And initially, there were 15 seats, currently 10 seats per year. Nursing also forms an important component in our teaching. We have a 2-year course in MSc Critical Care Nursing and a 2-year post-diploma in Critical Care Nursing for the PCBSc, and also the short-term 3-month certificate course for nurses from other parts of India. Some of the nurses have done PhD also from our unit. The medical non-university courses comprise of the various fellowship courses and the fellowship and diploma course run by the professional body, Indian Society of Critical Care Medicine, which recognize the need for critical care specialists before the introduction of formal critical care training. So the IDCCM and the IFCCM are the two flagship courses. Dr. Shalini Nair was the first candidate doing both IDCCM, later IFCCM. Postdoctoral CMC fellowship was started later. It's a 2-year course. And including all these 3 courses, we have about 83 candidates who qualified through these courses. And we are very proud of it because they are all spread all over India. The other course is the World Federation Society of Anesthesia sponsored training in critical care medicine. It is a 1-year course, basically primarily run by the surgical ICU with trainees rotating through other ICUs as well. And here is the list of countries, at least 10 countries. And we have had 30 candidates so far. And actually, they are doing very well. I visited ICUs in Nepal, in Myanmar, and they have actually improved on the existing ICUs or started new ICUs. And we are very proud that we are able to spread the knowledge of critical care throughout the world. FICCM is another course which Dr. John will talk about shortly. We conducted a lot of CMEs, the critical care CME, critical care ultrasound course, the basic and advanced run by Dr. Kishore, the foundation and preparatory course in critical care medicine, which I believe is very popular among the DM exam goings, the basic and very basic course, which is run by the Chinese University of Hong Kong, the AHA, BLS, ACLS course, which is initially started by the PICU and now joined by anesthesia, and some of our faculty are teachers in this course, and the CPR training undergoing in the institution. I'm proud to show you our founder members of the Department of Surgical Critical Care, Dr. Nandini Kurula, Dr. Prakash Kanduri, Dr. Nagamani, and members of the current existing team of doctors and nurses. And this is another picture with other members of the staff. Thank you very much for your patient attention.
Elaborating on this. Now we move on to the story of medical ICU, the evolution of medical critical care by Dr. George John, the former head of critical care and medical critical care.
I shall just bounce along the seeds of critical care, focusing on the medical ICU, because what we have now is a result of seeds planted by many people. Okay, this is the first seed already referred to by Mathew. The ICU was first started in the neurosurgical area by Dr. Jacob Chandy. And this is around 1952. I was born 1 year after that. This is the second seed. Nobody has referred to it till now, but this is the Department of Cardiothoracic Surgery, which started the second ICU in the late 1950s or early 60s. I'm not sure when. And Dr. Reeve Betts started the department, and he has done several cardiothoracic surgeries first in India. When the open heart surgery started, and Dr. Stanley John took over, and the ICU was the second ICU started. Now, this is an interesting point. Then the chest diseases department started off as an offshoot, and this is Dr. Millage. I found this blog on the net. He was actually studying acclimatization in the Himalayas. And he and his wife were in Nepal when Jacob Chandy invited them to start the respiratory medicine unit in CMC. They came over, and if you are interested in the blog, it is much more than what I have just copied and pasted here. He came over and started the Department of Chest Diseases. on invitation. And he invited Dr. Ray and passed on the baton. Dr. Ray actually graduated from Calcutta Medical College, went to UK, finished his training, joined the Modern Azad Medical College. I was invited by Dr. Milish to CMC, and he stayed on after that. And he was the first head of the medical ICU when it was started. Now, in our days, that was the Bennett ventilator, common sight in the wards. Patients got sick, they were intubated. We bagged and then shouted for help from Mr. Arthur and his colleagues. They had no cell phones. Before I joined, by the time I came, there was the bleep system. Before that, the attendant used to go with a notebook and he used to disappear for tea or coffee in between. So we had to bag the patient till Arthur came with a ventilator. And these ventilators needed no electricity. It was operated purely on the pressure in the oxygen cylinders. And so there was no problem about electricity cuts. But, you know, the hissing and puffing of the ventilator, when it started to grow faint, we had to call for the most important person at that time was the attender. He had to bring the cylinder, screwdriver, spanner, whatnot, and then change the cylinder on to the new cylinder. And this was the time when we used to sit on roster. We used to take turns from the medicine department, sit on roster, but that doesn't mean the rest of our work gets cut. After roster, you go back to the OPD or the ward. So it was a 24-hour day, and we continued this till around, and of course, when we were monitoring, we had no pulse oximeters, no ECG monitors. The finger on the patient's radial pulse was the ECG monitor, and the pulse oximeter was the eyes. When the patient turned blue or black, we knew that something was going wrong. So we were very untrained in this, but we used to bag whenever things had to be done to improve the color of the patient. Fourth seat, somewhere in the late 70s, I remember I was still doing my MD and Maman Chandy had finished his MD and he had joined M1. There were two patients on roster side by side. And it was putting a bit of a strain to carry on the routine ward work. So I went to him and said, sir, why don't we just combine this roster? He said, that's a good idea, we'll combine it. Combined it till one patient died, and then that unit left. So we were left again with no roster. So then we had the idea, why don't we combine interns on a permanent basis in a common area? That common area is actually the classroom for E-ward at the moment. So that was how the medical ICU started, and you can see the first budget. Bedside suction. I dug this out, courtesy of Mr. Balan and the CMC Directorate, from the minutes of the association and council. All the original paperwork was not there in the files. Parallel development, Dr. Nagamani and Subramani already talked about the surgical ICU. Dr. Ray retired in 1992. Then the Department of Chest Medicine, the pulmonary part was incorporated into Medicine 2. The ICU component and the ventilators were moved to Medicine 3, where I was there. And the subspecialty of MICU was established, and Dr. Ray proceeded on his retirement, and we multiplied through division. Since the E-ward area was a bit small, we requested for a larger area. We moved on to the present area. This is originally the cardiothoracic ward, cardiothoracic surgical ward. And this is part of the inauguration. We expanded into CNX, which became the MHDU. And from then on, we have moved on to the Ranipet campus, who proved a blessing during the COVID area. You can see several of the people sitting around us in the younger days, nursing staff. Dr. Lily John is there. Dr. Dilip Mata is inaugurating the unit. Then we integrated critical care into one division. Dr. Chelam Kirubakaran was the first head of the division of critical care, which had neuro, surgical, medical, and pediatric. But after she retired, pediatric ICU went on its own trajectory, and medical, surgical, and neuro ICUs continued as a division of critical care for purposes of training. And of course, no system is good without having people to take it over. And Dr. Subramani was crucial in starting off the DM in critical care. Of course, we focus on training the head, the heart, and the hand. Head, of course, you read and listen, and you do research. The heart you learn by seeing others doing it. It's caught, not taught. And the skills, you see one, do one, and teach one. And Mr. Arthur Sadanandam was on a parallel track where the BSc critical care technology developed. And of course, we had our surgical critical care nursing. I'll end with a few quotations. To see things in the seed, that is the genius. I think we're all grateful for Jacob Chandy for what he did in the beginning. A society grows great when people plant trees whose shade they know they shall never sit in. And the next one is a translation from Rabindranath Tagore's poem by Dr. Ray. Actually, Dr. Ray has got a full book of English translation of Tagore's poems. I happened to ask the destiny, who is it by unrelenting brute force is always pushing me from behind? Destiny replied, turn around and see. When I paused, I found out that it was my own self that I left behind, who was pushing me to the front. And also from the Bible, he also said, this is what the kingdom of God is like. A man scatters seed on the ground. Night and day, whether he sleeps or gets up, the seed sprouts and grows, though he does not know how. All by itself, the soil produces grain, first the stalk and the head, then the full kernel in the head. Thank you.
Now I invite upon Dr. J.V. Peter to elaborate on the present stature of medical ICU, one of the strongest pillars of our department, and the research activity of the department.
I'm indeed privileged to take on from where Dr. Georgian left. Medical critical care has transformed from a one-man army, which is Dr. Georgian, to 15 faculty, from 5 beds to 64 beds, from 750 admissions to over nearly 3,000 a year, and a mortality which was 40% is now down to less than 20%. Now, how did this all come about? There was the sowing of the seed, there was watering and nurture, and we see the harvest now. Dr. Georgian has been the mentor of a generation. He sowed as a leader, he led by example, he inspired, he was uncompromising, and he built. For him, no task was menial or challenging. He always volunteered to do Christmas and public holidays. He took equal duties till retirement, helped out with COVID work, and had a zero tolerance to bullying. He inspired many of us to take up critical care. Several generations of us have been trained. He was uncompromising, was willing to call a spade a spade. What needed to be done had to be done, and he was willing to point out errors and help correct system errors. Yet he was fun-loving. He was a leader builder who built many things, and I'll touch on this briefly. He built the intellectual capital for critical care, starting with Kishore, me, Vanilla, extended on to a second generation, a third generation, more DMs, and more in training. We are indeed very, very privileged and blessed to have such intellectual capital. But a team works with other members. We have been very blessed to have an excellent nursing team who stood with us. The addition of social workers added more to our quality. We have critical care technologists who have been contributing, and not to forget the secretarial and support staff who keep us going. These are some pictures of departmental activities, some of which have already been shown. And it is not just work alone. There's a lot of fun that medical critical care has. Second is the building of infrastructure for critical care services. And as Dr. Georgian pointed out, we grew from a 5-bedded ICU where we used to work. I remember those days, to 11-bedded ICU. I still remember the medical superintendent coming. We had only 4 monitors, and we used to have the arterial lines of 2 patients connected to the same monitor. And unfortunately, one of those days after the current cut came, the traces flipped, and we didn't realize. And we were actually increasing the inotropes and wondering why the blood pressure was not coming up, till we recognized that the traces had flipped. I got the medical superintendent and said, we need more monitors. He said, no, you can't have more monitors. You still have to use this. I said, how about putting 2 patients on the same operating table and operating at the same time? And that's how we got more monitors. During my post-fellowship, we had 12 ICU beds where we had ICU faculty supervision and more contribution from others. These are some photographs of the inauguration and dedication of the MIC and MHQ, which happened in 2009. The COVID pandemic enabled us to have more surge space. The STICU was created in a record time of 1 week. And during the peak COVID, we had 250 ICU and HDU beds, and it was a pan-institutional effort to manage these patients. From 2022, we have the Ranipet campus. So we have 30 beds in town campus, 34 beds in Ranipet, and we have a team of faculty, senior registrars, PGs and non-PGs who help manage these patients. And future expansions are planned in Ranipet and town campuses. A brief mention about the COVID work where initially medical critical care was involved, then neuro, surgical, and several other departments pitched in. It was a pan-institutional activity, as I said, and I was able to locate the slide in September 2020 where there was always a pressure for critical care beds, and a lot of patients, nearly 20,000 patients were managed in our hospital for COVID. CMC has been in the news for COVID, and I want to particularly point out that the use of non-invasive ventilation was popularized at a time when everybody felt non-invasive ventilation should not be done. And the department participated with a lot of activities and training. I was very much touched by this Messengers of Peace piece where one of our attenders decided to work in the COVID ICU despite his age and his comorbidities, and that shows the commitment of each and every one of our staff during the COVID experience. I also want to briefly talk about equipment for advanced care. This is what was developed in medical critical care. A lot of indigenous development for CPAPs, all scavenged from ventilators that were thrown away, spirometries. And from there, we have moved on to have POCUS, multi-parameter monitors, point of care blood gas, and now the MRI compatible monitors and ventilators for the entire division. We migrated or we improved from just having Puritan Bennetts to HFNC, NIVs, high-end ventilators, and ECMO, which was a CSR initiative during COVID. There are other things in equipment that we have added on over the years. The dream for us in medical critical care is to have an integrated command and control system with tele-critical care services. Unfortunately, we lost out on the ASHA grants because of the closure of the grant, but we hope one day this will happen. A lot of emphasis was put on safety and quality. I'm not quite sure when it started. Dr. Georgian was very particular, and I remember when I came back from Australia, I was very impressed with the emphasis that he brought out on quality and safety in terms of reporting adverse events, regular quality meetings, doing root cause analysis and corrective measures. This is how it was done in those days. And now with Benila having been involved in quality and safety for the institution, we have an online reporting system. Dr. Georgian also contributed to the guidelines for quality indicators for the Indian Society of Critical Care Medicine. So medical critical care has played a pivotal role in improving quality and safety. We used to have campaigns, slogan competitions in the initial years, and the accelerated emphasis came during swine flu, when Dr. Georgian was actively involved in the guidelines for the management. And then, of course, Benila took over with passion and purpose. She made sure that all of us washed our hands and did all the other things that needed to be done. And we have seen an improvement in terms of infections with a reduction in the infections. Fire drills started from MICU. These are pictures from 2011, and now it's integral part of the institution. Dr. Subramani has touched on most part of the education. I just want to focus on the Australian affiliation with the College of Intensive Care Medicine. We are the only accredited unit, and I came back. Dr. George John and I were trained in overseas, and Dr. Ross Freeborn came for the accreditation in 2008. We are one of the 10 accredited units overseas, and several of our graduates have been trained with the Australian group. This is an excellent resource that Dr. Georgian has invested and put in, and it's very popular. Imagine more than 1,000 copies of his book having been sold. It's copylifted. We also have the MICU guidelines, which is undergoing a new revision. Dr. Georgian, I remember when the three of us were there, he said, you take on this, you take on this, you take on this, and he delegated responsibilities. And Kishore was tasked with developing the ultrasound and sonology course. He designed his own website. There have been so far 32 basic and 27 advanced workshops. Over 800 clinicians have been trained. Now the entire department of critical care is involved, and people have come from Germany, Australia, and SAARC countries to be trained in sonology. Dr. Subramani touched upon this. It was initially started with few of us becoming instructors. Other than basic, we have very basic, beyond basic care and basic research. Some of us have been trained in this, and we pass on our knowledge and skills to others. Dr. Georgian actually gave a acronym and said we should have a Center for Sonology, Simulation, and Skill-Based Learning. And so as an offshoot of that, medical critical care, and now the entire department is involved with simulation training. We are involved with BLS and ACLS workshops. And these are some of the activities of the skill labs that we have. ECMO services in the department was started by Dr. Benila. She trained in Australia and started these services for critical care. And that has got a lot of traction with the news media also picking up the work that has been done, innovative work that has been done for through ECMO. There's a lot of training focus, which Dr. Subramani had pointed out. Research is extremely important. We are a young department, so you may not find the volume of publications that other older departments have, but we have about 500 publications as a department, which is pretty good. And our work has been recognized, and surgical critical care also has a patent. And these are some of the areas of interest that our faculty are involved in. So the result of all this has translated not only to increase in patient numbers, as you can see in the graph, and those are the time points where more beds were added. It is also translated to a reduction in mortality of our patients admitted to the ICU. And as Jay alluded, from where we were to where we are now is mind-boggling, how much we have advanced. It is also translated to a very vibrant team that we have in medical critical care, young dynamic field who keep us on our toes, make us read regularly. They are not only ready to conquer the world, but they're ready to conquer the critical care field. We are very grateful to be part of the journey. Thank you.
Thank you, sir. And that brings us to the end of this heritage lecture. We thank Edmund. We thank everybody who's here. Thank you for your patient listening. We shall now have a departmental photograph. Thank you.